Okay, good afternoon and welcome to Forum 2. The title of this session is Rendez-vous, or Rendez-vous with Myval THV Series and Landmark RCT. Who in the room here knows what rendezvous means? And you can't be from France when you answer. Rendezvous means, anyone?
Getting together.
Getting together. So it's a getting together, it's a meeting to discuss the Myval THV series of valves. And with us we have a group of physicians with great experience with the valve. So maybe we'll just go around and you can introduce yourselves. Here you go.
He's got a microphone.
Yeah, my name's Philip Freeman. I'm interventional cardiologist in Denmark, Aalborg. We were part of the THV Compare team. You've just maybe heard the results in the main arena a few minutes ago.
I'm Ravinder Singh Rao. I'm an interventional cardiologist in Jaipur, India.
I'm Ignacio Amat Santos in Valladolid, Spain.
And Andreas Baumbach, I'm from London, the UK. I was the principal investigator together with Sir Royce, Professor Sir Royce, of the Landmark trial. Lots of experience. I'm going to be the cubes person in this session. The way it works is I'll throw, you have to catch, and then you have to speak into the microphone.
Good evening.
Well done. Okay.
Okay, so what are the objectives of today? So really it's to learn about the Myval THV series of valves, to understand some of their key features, some of the procedure and clinical benefits for our patients. We'll be discussing the pivotal Landmark randomized trial. We're also going to look into what's special about the series of these valves. That is, they have intermediate sizes, 0.5 millimeter sizes, and more specifically, they also have XL sizes in order to treat some of our patients that can't be treated with our current technologies, and also to discuss some of the relationship between foreshortening and accurate valve deployment when doing these procedures. So let's start with the first series of lectures.
That's me, is it?
Go ahead, Philip.
Can I take... thank you. Hi again. So... just get my slides up there, or do I have to select it?
I think you can, yep, you probably can start it there, that's true. There we go.
Here we go. As I said before, my name's Philip Freeman. I work in Aalborg in Denmark. We're one of the 3 centers that performed the recruitment for Compare THV, which you've just had the results of probably in the main arena. I'm going to give you a quick introduction to the Octacor series. Merrill Health have invested in a huge number of research projects, including 2 major RCTs, the Landmark and Compare THV. Compare THV was investigator-led, and we've just heard is shown non-inferiority to the Edward Sapiens series. I think it's a company that has some faith in its product, and we'll be hearing more and more of that from the various randomized trials. The Octacor system is a direct crimp valve. It direct crimps onto the balloon. It has a flexible delivery system, quite different to other balloon expandable systems. Has minimal foreshortening, enhanced hemodynamics, and also the Octaline. We're just going to quickly go through some of those major features. The Octacor has 2 rows of octagons, and this allows 2 important things: symmetrical foreshortening from the aortic and the ventricular side, making it quite predictable, and also fairly minimal foreshortening, around about 20%, which is a good way less than the self-expanding valves and other balloon expandable valves. As you can see here, positioning is quite easy with the delivery system, very flexible. The foreshortening is symmetrical from both sides, and you can see with the right kind of techniques, you can get a very nice high implant and minimize your pacemaker risk. The Octaline, we can briefly talk about. I'm not going to go over this in detail. It's a nice way of taking some CT data, looking at your commissures, You can align things either to the coronaries or to the commissures. You take that CT data and basically clock the valve as you crimp it. And that seems to work quite well. There'll be some more data coming out in our CT sub-study from Compare TAVI about just how well that works. But certainly, when you make an implant, if you're in the 3-cusp view and you see one of the pledgelets right in the middle of the right cusp, it means your commissure alignment has worked. And that's what you see in the majority of cases. Commissure alignment is extremely helpful for tight spaces. You can see the pictures on the right is the basilica case we were doing. And obviously at the end, such small sinuses at the end of that case, the last thing you want is to have a pledgelet or a commissure right in front of the left main stem. That's also important for lifetime management. The first cut is the deepest. Having commissure alignment, especially in a lower risk, younger patient, is critical to allow easy and multiple options for valve number 2 if it's necessary. Hemodynamics, we've seen from Landmark quite considerably improved hemodynamics with Octacor. Primarily that's because of the way the leaflets are sutured to the frame. There's no thickened pad between the frame and the leaflets being sewn on. And that makes a big difference to the EOA. That data is now being repeated. We've only seen the headline data, but we've seen a clear advantage to Octacor in terms of hemodynamics over the Ultra and Sapien valves. We have seen higher pacemaker results, and we can't ignore a 20% pacemaker rate. Now, I don't know exactly why that is. That data will come from some of our CT analysis later. But my speculation is this is about implantation technique. The problem with Octacor is that a lot of people will go into a Myval implantation who are previous Sapien implanters, and they'll implant it in exactly the same way, and that just doesn't work. The delivery system is alive. You can see from this picture here, a case I did a few weeks back, a 32mm Myval, how mobile the delivery system is. And you need to use a different technique with Octacor. It's a wire push and a device push, so you can get the valve onto the outer curve, coaxial, and make a nice implant. The next picture is just doing that wire push and device push, nice high, and everything stays very, very stable. The valve doesn't dive into the left ventricle. And this is certainly how I've optimized my implantations over the last little time. So I personally think that high pacemaker rate is to do with technique of delivery. So we need to finesse that. We need to improve the consistency for all operators. Maybe even consider doing implantation in cusp overlap view to make sure we're staying away from the membranous septum. And I think that will enhance things just as it did for the self-expandable valves in the early days. Thank you very much.
Okay, Philip, what we're going to do is we're going to listen to the second lecture, and then we'll open up the room to discussion. So, Ignacio, you want to tell us about the Landmark randomized clinical trial?
Thank you very much. Probably everybody who is in this session is interested in the technology and has already read the Landmark in detail. Also, you have the PI, Professor Bambach, you have Professor Series, so the tricky questions can be directed to them. I will just summarize a little bit the most important points of this study and the relevance they might have in our clinical practice. So this is on behalf of all the investigators who did great effort, also the research units in each institution that help a lot and keep on helping because this trial will keep on for 10 years, so there will be 10-year follow-up. And the design, you'll know, was a randomized study between Myval THV Series and what could be considered the gold standard, including contemporary valves, Evolut Series, and Sapien Series. As I mentioned, the 30-day outcomes were presented in PCR last year. This next year, 1-year follow-up outcomes will be presented. And these are the devices that were used in the comparison. So all the standard sizes, 20, 23, 26, 29, but also the intermediate sizes of Myval technology that will be later presented more in detail, and all the sizes for Evolut, except that 23 was not used. The investigators did not choose this size in any patient. It's very uncommon to use a 23 Evolut anyhow. The primary endpoint is very interesting because this was one of the first head-to-head comparisons of devices taking into consideration VARC3 criteria. Now we also have the IDE trial, but this was VARC3 criteria. And the composite included what we care when we are doing TAVI. Included death, included stroke, bleeding, major vascular complications, kidney injury, moderate or severe regurgitation, and pacemaker need after the implant. So this was the primary endpoint. And this was the key result of the study. The primary endpoint occurred in 24.7% of the patients in the Myval group versus 27.0% in the contemporary cohort. This means that this met the non-inferiority, and the upper one-side confidence interval was far from the 10.4 margin that was settled, and the p-value 0.0001. So non-inferiority was clear in this setting. If we go one by one, seeing all the individual components of the primary endpoint, mortality, stroke, bleeding, etc., we see that there are no significant differences in any of them. So it was only the primary endpoint. And the hemodynamics, Philip already saw this slide. This was super interesting. We have explored this retrospectively, and we found this difference in hemodynamics. But of course, that was a retrospective study. We didn't know if there was some kind of bias selecting the patients. But the prospective study confirmed that for the 23, the 26, and the 29 balloon expandable valves, Myval performed better in terms of hemodynamics. And it performed similar to Evolut series. So it was more comparable, the hemodynamics that we obtained with self-expandable. This is something that was presented today, if I'm right, in your intervention, and is the one-to-one comparison of Myval versus Evolut and Myval versus Sapien, where we can see that the effective orifice area for Myval, in this strange blue color or green, was better for Myval than for Sapien, always a little bit higher for self-expandable, for the smaller sizes, and for the normal annuli as well. So we get better gradients and better effective orifice area with this device. This is the publication that I just mentioned, that just appeared today in your intervention. And this is the publication of the Landmark trial in Lancet. We performed a meta-analysis. Now we need to update it because compared trial was presented today. In this meta-analysis, including Landmark, effective orifice area for Myval was 1.92, mean gradient 8.5, moderate or severe regurgitation 126, all-cause mortality at 30-day 195, and stroke 1.3. And what about long-term outcomes? Of course, we don't have them, but we have some information from clinical practice that I want to mention here, even if it's out of Landmark trial. And it's in our clinical practice, we already have patients with 4-year follow-up outcomes, and we find that we did not have to treat any valve, there was no valve failure, and there were preserved gradients and effective orifice areas. And I could not resist to take a photo of compared TAVI, and I have to mention it. And it was just presented a few minutes ago in the main arena, and it demonstrated that Myval versus Sapien 3 series was non-inferior also in that trial, specifically designed to compare the two balloon expandable devices. So in conclusion, Myval is a competitive balloon expandable TAVR device. It is simple, directly crimp on the balloon, easy to position. It has some differential factors that will be discussed in the following presentations by Nico and Professor Bambach, extra large annuli, intermediate sizes, and therefore it seems to be competitive at short and mid-term, and probably we will have comparable data to what we have in clinical practice at longer-term follow-up. Thank you very much.
Okay, thank you very much, Ignacio. So here you go, Andreas. So we have about 7 to 8 minutes for discussion. So anyone in the room want to ask the PIs or who are here, or those with experience implanting the valve, any questions about what we've seen?
You can also ask your questions via the app. They will appear here, and I will read them out, and we will try to answer them.
Anyone? Okay, here, let's...
Up you go.
Stress here. No, I think what is important, and in the 2 following days we are going to talk about that, is that although the fact that the 23 Evolute was on the shelf during this trial, it was not used. And if you look at SMART trial, it's only 2.3% of the 23 who has been used. So what you have is that the 26 goes systematically in these small annulus 430. And we will discuss that tomorrow. On one hand, of course, you get some lower gradient in the small annulus and larger orifice area, but there is a price to pay. And the price to pay is the paravalvular, not the paravalvular, the prosthetic, the prosthetic valve regurgitation. Because when you put this big self-expanding in small annulus, on echo you see that they are asymmetric, elliptical. Yeah. So you have a pinwheeling effect there, and you have some central regurgitation. And it's not small. It's 11.9 for Evolute, while it's only 1.7 for the Myval. So that's something, there is a price to pay. Vice versa, if you look at the Sapien, it is clear that you have Sapien and Myval with the same fitting index, but there are also a lot of patients outside the fitting index, and then you see suddenly the pacemaker rate increase that. So for the same fitting, same pacemaker rate, Sapien, Myval, but when you have not the good fitting, you put a too big Sapien in a valve, then you get also a price to pay, which is pacemaker.
Yeah, Andreas, you have some experience with the valve as well. Do you think the intermediate sizes, the 0.5 millimeter sizes that are available, lends to better hemodynamics because you're really tailoring the valve for the anatomy? We didn't have that in the past. Now we have a myriad of valve sizes, right? And do you think that fits into the equation of getting better gradients?
You know, I'll show a couple of slides later on, but it is very evident the moment in clinical practice, I'm not talking a trial, in clinical practice, the moment you have intermediate sizes, you're going to use them. Because intuitively, of course, you want as ideal an implant as possible. You wouldn't want to oversize or undersize because you just have to, because you don't have the right size. If you have the right size, you use it. Of course, we think, well, we know the hemodynamics are very good. In the long run, my hope is that that also, translates into an optimal valve function over time, less valve deterioration, but that's speculation.
Yeah, the other thing that, while we're looking for someone in the audience to maybe make a comment, the other thing that...
Isn't that a good throw?
Andreas, the other thing that's interesting about these intermediate sizes is that, at least for me, it takes away the guesswork of, do I add 1 cc? Yeah. Do I add 2 cc? Do I minus 3 cc? I still don't understand how to do that.
Plus 3, plus 2.
Right, and when do you do that? And how do you know that that's the right thing to do? I think now that you have these intermediate sizes, it's what we've been missing all along.
Yeah. I mean...
Speak into the box.
Yeah.
So for subcontinent, intermediate sizes are more important, especially in Asia, because we have a lot of bicuspid anatomies, and we know that the number, for example, if we take 24, 24.2, earlier we were leaning toward a 26 balloon expandable, but with this, it's 24.5. So for sure, it becomes much more easier to treat such patients. So it really optimizes the patient's anatomy, I would say.
Okay, good point. And you throw. So shall we talk about the performance of the whole system? I mean, who has used the Myval or Myval Octacor in this room? Still a minority, yeah, but some. Can you tell us how does it perform in daily practice?
So my main practice is in the United States. The cases that I've performed for Myval is in India. So I can give a direct comparison for Sapien versus there. Like the first thing is it's directly crimped. It's easy.
It's crimped on the...
It's crimped on there. And the main difference or the important thing which I found out was the intermediate sizes, especially in the bicuspid, so you don't have to oversize a whole lot. And when you talk about removing 3 cc's out of it, then you wonder that the valve will not expand. You end up in pinwheeling, and then you have no idea whether you'll have hold down the line or the valve performance is going to be affected. So intermediate sizing, I felt, is a much more advantage, and direct crimping, which makes it a lower profile.
Just a short note. I mean, the people sometimes said, is the align working in the bicuspid? Of course it's working. If you take the right coronary artery and outside the body, you align the commissure on the ostium of the right, tricuspid or bicuspid, it doesn't matter. So the message for the audience, you can also do the align in the bicuspid. This question comes very frequently.
Okay.
Anyone else have any questions, comments about the system?
On the system itself?
Yeah, so regarding this, I would say that sometimes, in bicuspids, you might have an angle in between two coronaries, which is like 150, 160 in type 0 bicuspids. In that situation, I mean, we know that the commissures are aligned at 120, so then you'll have to look whether which coronary is above the level of valve risk plane. You can spare that and just align with the left one rather than going with the right one. Or if both are really important, then probably you can distribute this 30 degrees, like 15 mismatch to the right and then 15 to the left, so that it's a mild misalignment for both rather than giving severe misalignment to the left main. Because if you align it with the RCA, then it would be like 30 plus misalignment to the left main. So I think it's important to know whether the RCA is dominant, is occluded, which is above the level of valve frame, and then probably you can tailor the requirement of this alignment rather than having a standard with RCC alignment or probably the right cusp. Also, this system, you can retrieve it outside the body. So that's a major advantage, because many a times in bicuspids, if you have to go with a sapien, you will go with a stiff wire like Lundquist. You will aggressively predilate and then you go in the valve, because you know that you cannot retrieve it outside the body. But in this case, you can probably start with a softer wire, softer balloon, try with the valve, doesn't go, take it out. It also helps in mitral position many a times when the device doesn't cross. You can change wires, you can put 2 wires, you can use other techniques. That's what I think.
Yeah, that's a good point. So, Andreas, you've been part of the randomized clinical trial. What part of that trial, and even Professor Serois can comment on, what part of that trial really was exciting or really stuck out as something you weren't expecting?
I mean, first of all, it was a bold move to have a new valve and go in with a proper randomized control trial against...
And Andreas, sorry, before you get there, how many cases had been done before starting the randomized trial? Because you got to think, you're competing against 2 valves that had started from 2002 and 2004, and now you don't have that sort of, takeoff or roll-in phase, so to speak. How many cases had been done up until then?
I looked at but it was mainly in India, the first in man, and then several hundred, if not 1,000 patients.
Okay, there wasn't 10,000 or 5,000. It
was beginning. I think the beginning of the curve, and so that was a bold move, and the setup was a proper randomized trial, and that's again, just speaks to the policy to really test this device properly. What's standing out is that the operator experience that you get back, the feedback from the participating centers that took that valve on as a workhorse valve. It really, can be used in all the patients, as we have seen now today, confirmed in the COMPARE TAVI trial.
Yeah, and Ignacio, go ahead, Ignacio, go ahead, and then we'll have Professor, go ahead.
On COMPARE, they mentioned they have done 500 sapien cases, at least each of the centers, before the randomizing. Yeah. They didn't mention how many Myval cases they have done.
It wasn't
Denmark,
very many.
but maybe because it's Denmark.
Sure. Maybe 20.
Just highlights the ease of use of the device, even for a new operator.
Right.
Yeah. I think what was interesting is that introducing something new, like the intermediate, was embraced immediately. I mean, 48% of the investigate use the intermediate. That means it's a response to an unmet need.
Yep.
And before that, all the percentage around the world was also 48%. So it was not an easy trial, and we don't have to go to the peripecia of this trial. But I think what is very important is that we had to go to European countries which was not too much in the pictures, okay? Slovenia, Slovakia, and so. So I think this trial represents very much Mr. Everybody. It's not the prima donna, you know, it's not the DGHHA multiplied by 36. No, it's really guys which are in the field, good operator, and it's very important to see this result. And the reality, if you do a big meta-analysis on pacemaker rate, which was just published in 21,000 patients, the rate of pacemaker is 17%,
yep.
that you like or you don't like it, okay? And if there is an odd ratio, it's more for the self-expanding than the balloon expandable. So I think it represents a little bit what can be done on the continent. Yeah.
Okay. Andreas, we're just on time. We're doing well on time. Why don't we carry on with the with your next lecture? And then I'll give the lecture on Excel, and then we'll have another discussion.
Let's do it that way. So these are actually not my slides, but Stefan Hausig couldn't make it because of the storm. So weathering a storm, I give those slides. Matching prosthesis to patients. Where is the advanced? There we go. This one. So we have seen that and we have discussed that now. This is what was there before, 2023, 26, 29. And what we have now is the 21, 24.5, 27.5, 30.5, and the XL, which will be discussed in a separate talk. So the first, really a unique feature of this valve series is the dimensions. They are much expanded and make us treat patients with a larger range of aortic anatomy. And again, this has been talked about. On the left-hand side, the landmark population, 52%, 48%. The red is the conventional, and the blue ones are the intermediate sizes. Replicated, or it was there before in the matchball study, 55-45. Kawashima 57-42, and then Halim 47-50, half. And it's obvious, you have a range of aortic annuli, and half will fall in the intermediate sizes, and that's what we see in our practice here in London as well. Now, the fitting index has been mentioned. This is, I think, originally an idea of Axel Linke, that came out of the investigator meetings for the Landmark trial. What it means is simply, how close is the valve size, the nominal valve size, to the actual annulus diameter. And here you can see an example at 21.5 in a annulus that has a derived diameter of 21.1 or perimeter derived diameter of 21.4, so a little bit of oversizing, but a fitting index of 1.02 or even 1 if you round it. And this is the final slide. This is what happens if you calculate the fitting index, and you've got the purple line, the Myval series. You see that more of the cases are within X and Y, meaning in the optimal range between 1 and 1.05, right? The yellow ones are the sapiens, and they are more on the outside, undersized or oversized with 1.1 or even 1.2. What that means for pacemaker implantation is just briefly shown here. The rates in the ideal fitting range were 15 and 14.1%. But if you look at the lower fitting index, the rates in the valves that have intermediate sizes, they're still closer to the lower rate, and there is a price to pay if you use the valve that doesn't fit that well, and the same, not quite there, if you oversize, it's pretty much the same numbers. So that much to the fitting index, the intermediate sizes, and a bit of an impact on pacemaker rates. Over to you.
You want to give him the box?
There is a
Which
little bit hype in the United States about...
Professor, which one would you like?
That one,
yeah,
the full one,
Stay
right?
on this one. There is a little bit of hype in the United States with self-expanding is made for the women, okay? I heard Roxanne Meran saying that.
Small.
But if you look at the dimension of the 26, the Evolute 26, look at the annulus diameter. It's something which is 62.8 versus 72.8. Nobody has used the 23. Now you put that valve in the annulus area of diameter of 18.6, 20.7, and 20.4, yeah? You can see the difference. So basically the instruction for use are not respected, yeah? And there is a price to pay for that. That is prosthetic valve regurgitation, the pilling effect, the fact that these valves rotated and leak centrally. So I think we have to be careful before saying that the self-expanding is the valve of the women. Yeah, I think that has to be revised maybe.
Good point. Thank you.
Okay, so the next few minutes we'll talk about XL size relevance and you know, whether or not it's important in our clinical practice and what it means. Now, just want to say thank you to Alfonso for giving me some of the ideas on these slides. In Canada, we don't have approval of the Myval THV series yet. And so we need to find indications that are not there in order to get special access. And so our special access for Myval has been in large annuli. Now, what do we have in terms of maximum annular range? And look at the area column first. You can see that the number that pops out, maximum, is about 700, okay? So keep 700 in your mind. If you look down the column of the perimeter, it's 95. So keep 95 in our minds. And then for diameter, it's 30. Okay, so if you ever think, what is the maximum annular range we can treat with our current devices, excluding Myval, we have 700, 95, and 30. Okay, so this is the unmet need, is when we get into clinical practice and we find that we have annular ranges that exceed the current devices. Now, sometimes we say, okay, let's use the largest device that we do have and try to make it work. But of course, we should think anything's feasible. We can put a valve in any patient, but we need to think about safety and efficacy. So this is a paper that looked at about 2,000 patients that had been screened for TAVI between a certain number of years, almost 10 years. Now, if you look in that graph that plots the number of patients versus the annulus area, that square, that red square, represents those with an annuli greater than 100. Now, in this study, they found 2%. Now, back at home, we don't do 600 TAVIs. We do about 200, 250 TAVIs. But I can tell you that from there, we do about maybe 1 or 2 or 3 special access requests for the XL. So you multiply that by 12, you're going to get about 24 cases per year, let's say, divided by an average of about 200, 250, you're looking at about 5 to 10% easily, okay? So I think what percentage of our screened patients have large annuli? I would say about 5 to 10%. Now, how does Myval fill in this unmet need? Well, we've been talking about it all the time, but here the two numbers we want to remember is 30.5 and 32 millimeter valves. Those are the two valves that can treat the annulus above 700 and above 30 millimeter diameter. And although the IFU here says a maximum of 840, we have done, at least in our center, even larger than 840. And as I was speaking to some operators before, it has gone up to 1,000 millimeters squared. Okay. Now, of course, you got to measure the amount of calcium you have in the supraannular area. You might not want to do that with pure aortic regurgitation. But there is a possibility to even expand and add those extra cc's in the large 32 millimeter XL valve. Some of the characteristics here that we speak about, and I just want to go down to the foreshortening characteristics, because every time you have a large annulus, your valve has to expand to that opposite side. And it's very uncomfortable when your valve foreshortens and you don't have a good feeling of how that valve is going to behave with the annulus. And so you really want to minimize the amount of foreshortening. This is just the percent foreshortening of the crimped versus fully expanded valves. You notice that we have about 19 to 20% with the Octacor. With the Octa Pro, that's going to go down to about 10%, okay? So even less foreshortening compared to the other balloon expandable and self-expanding valves. Now, just wanted to share you a case example in someone with a large annulus and bicuspid valve. Notice that the annulus area is 718, so above that cutoff of 700. The LVOT is smaller, so we call this a tapering anatomy. And this tapering anatomy is always more favorable than the tubular or the splaying anatomy. And this was a right-left fusion. The other thing is that you're using these big valves, the 30.5 and 32, but it still fits in the 14 French expandable Python sheet. So that's also very important. And, you know, this is just an example. You can see that the foreshortening is very minimal. And on the right-hand side, an example of the result. You can see that the valve has great radial force. It's fully, it doesn't appear to be underexpanded with minimal leak. The next one is just a case of pure AR, no calcium, as you see on the complete right-hand side. And you have an annulus area, again, above 700. Again, you have a tapering anatomy. Here's just an aortogram of the severe AR. And you can see the positioning where you have the dot marker on the valve, on the crimp valve, just at the annular area. In the middle, you have a post-dilatation to optimize the results. And on the complete right-hand side, you can appreciate that you have a very nice positioned valve with trivial leak. Now, there's been clinical case series looking at specifically the large annuli across different publications. As you see here, some of them are subgroups of the case series, but most of them are suggesting that we get excellent results in these large annuli. And of course, there's this landmark trial that we've been talking about, the randomized trial. There's a nested registry in there looking at the XL sizes. And the recruitment in there is still ongoing. You can see that there's approximately 70 patients that have been enrolled across 44 sites. Thank you. Andreas, we have time for discussion now.
How's it going?
Right here.
You do?
Nico, it
Yes.
was very interesting, the indications, and I agree with the percentage that you mentioned, around 5% probably of the stenotic patients. Then the pure regurgitation is another off-label use. We are using more in that setting now than in stenosis, but also failing tricuspid rings, large pulmonary valve disease. In all these settings, we are using these extra large sizes. This is, of course, off-label, but we asked, that was unmet completely. We didn't have any alternatives.
Yeah, valve in MAC, for example, the 32 is a go-to time and time again. Very, very useful.
There you go.
I have one question for my colleague from India. I mean, the last time I was in India, I was talking to a physician who said, yeah, this year we have done 300 surgery for valve in, of course, rheumatic articular, yeah? And I said, why it is not done? And he said, yeah, but you know, that pathology is much more slippery. I said, if it is true, you should do what Rendez-vous has done many years ago. At the time of the surgery, put the valve there and try to remove it. And you will have, because this is just an intuition that that pathology is more slippery and the valve will not stay in place. But you have 300 quite young people, as a matter of fact, operated. I mean, that's something should be considered. Any reaction from India there?
So, Professor, maybe I can answer that question. Majority of these patients who undergo surgery are candidates for mechanical valve. So they are not candidates for a tissue valve anyhow. But once you cross, let us say you've crossed the age of 60, 65, that etiology becomes like a combination of rheumatic as well as degenerative. So one of the reasons why these young patients are not even being evaluated for a TAVR valve is because they all need mechanical valve and they have some sort of indication for anticoagulation, maybe chronic AFib and large LAs and all those things.
Yeah. So who here in the room performs TAVI? Yeah. And how many of you sometimes don't treat your patients because they have a large annulus? Anyone in the room? Yeah, yeah. So maybe just, you know, what have you been doing with these patients, out of curiosity?
Sorry?
So you said you have patients that sometimes have too large anatomy, and yeah, what do you do with these patients? Do you let them be? Do you do a balloon valvuloplasty, or do you push
we have available different devices for this kind of patients. Since we have the valve from Myval, we try to use in this particular setting of patient, or probably with pure aortic regurgitation, or bicuspid patient, we usually try to put a Myval. If we don't have the opportunity, probably we will use a auto-expandable valve like Evolut Pro, or that's we have in my country. But
sorry, where are you from?
Argentina.
Argentina. Okay, so you have Myval in Argentina. Okay, very good. Where's Imran? I just wanted to ask. Where's the? Throw the box to Imran. Where is he? Okay, Imran is coming. Hold on. I want to ask you a question.
So we have a lot of experience with XL Myval in Argentina, but what do you think is the limit? For example, I have done a case with 32 plus HCC.
8 cc?
8 cc, yeah. It was really really bad patient with it was almost urgent case. We don't have any other experience. We had another option. We couldn't operate him. So it fit because he had a lot of cases. It worked. But what do you think which is the limit about overfilling?
We have someone there.
I think, you know, if we have more of those patients, they need to build us a bigger valve, a larger valve.
I'll give the answer in terms of the aorta as well as the pulmonary. So I was the first person to implant the 32 mm in India. So that was actually a very large size. And recently we did a pulmonic with a Myval, which was manufactured, and it was a 36 mm annulus. We made the 35 go up to 38.
So there's a 35 in India going up to 38. Okay, so
But
that's your answer.
from my experience, to answer your question, I think in reality, +6. When you start pushing it beyond +6, you can expect some issues. I did a tricuspid case in Leeds where we went the same, +8, +9. And I think in those situations, you have to think ahead and think, okay, I might need to use a second valve inside, and you know, probably there isn't, but you know, coronary obstruction or any other anatomical reasons why you couldn't do that.
So when you say +6 is your maximum, what does that translate into area? Because we said 700 before. What does this translate when you +6? What's your upper limit then?
It's going up to about 1,000.
About 1,000. Yeah. Okay.
Yeah.
Okay.
So. So same question, like, you know, because with the new design of the Octacor, like, you know, my primary use is Sapien. Like, you know, people have talked about on social media adding 10 cc's. I honestly do not know what happens after 5 or 6. Like, does the cell design has that in it to go beyond that, right? Like we talk about, you add a cc, you add 0.5 millimeters in the dimension, right? Or you add like whatever, 25 or 50. But it's, it's give or take. It all depends upon the calcific anatomy. So with the octacore design, what is the limit? Like, to follow up on that gentleman's question, like 32 plus 10, are we getting additional 5 millimeter? Is the valve design up for it? I don't know.
I think there must be a limit
There must
to
be a limit,
what you
especially
can
with
do.
two-cell
We'll have to
design,
ask the
it grows.
engineers, but actually,
Yeah,
of
that's
course,
an
they're not
engineering
allowed to
question.
answer.
That's an engineering bench test. Yes.
There you go.
Don't tell me you had 15. Don't say you had 15 mm.
No.
This is not a contest.
There is a chart which is available up to plus 3 cc's, which is sort of, benchmark. But beyond that, we don't know. But plus 3, till then, it is documented that it increases 0.3 millimeters with every 1 cc which you add extra. So maybe 27.5 minus 2 and 26 plus 2 are almost going to be similar. That would be 26.6. This would be 26.9 or something like that. Yeah.
Yeah, I wanted to give that box to Imran.
Imran, there you go.
You know, we got a user from Argentina, from Canada, from all parts. How many countries are performing Myval right now?
So more than 75 countries are performing.
75 countries.
Yes.
That's incredible. And how many centers?
So many centers.
More or less. There's a lot of centers. Multiplied by
like
something. Okay. Yeah. So
1,000
several
plus
hundred centers. Yeah. Okay. How are we doing with time? It's 6:09, Andreas.
One more talk.
You know what? We're right on schedule for the next. So,
Right.
Ra, why don't you give us your lecture, and then maybe we might have a few minutes to discuss, and then we'll make some closing remarks.
So my talk is on relation between THV foreshortening and accurate deployment, the pro effect. Do we really need this? I mean, you saw about Sapien, Myval, then you saw Octacor. Do we need another valve which will help us to deploy the valve at the right depth? So if you look at the compared TIV, which was just presented, the pacemaker rate was slightly higher. Here also the pacemaker in the Landmark trial, majority of patients got Myval. There was some patients who got Octacor, and the pacemaker rate was still in double digits. Professor pointed out clearly in a meta-analysis, the pacemaker rate is 17%. So can we optimize it even better? Can we do a good job in deploying the valve? And the other important thing, which was highlighted by Nico and all others, that compared to an experience of 500 already existing balloon expandable valve versus starting with the first valve as your trial patient, the operators and the outcomes were comparable. So this we all know, but the new difference, the new development, which is an engineering development, so don't ask me any engineering-related questions, is the foreshortening is almost negligible to the naked eyes when you are watching on a fluoroscopy screen. So the foreshortening in the OctaPro is around 10% from both sides, which you will not be able to appreciate when you are doing a valve deployment. So how does it help the operator? It is more of a predictive deployment. You position the valve at the place where you want it to be in the final position in the LVOT. And that's where the valve is going to stay in place. And we're going to show a live in-box case tomorrow how we started, and that's where we ended. This becomes important for the new operators and new centers because when we are positioning the already existing balloon expandable valve, we are calculating in our mind that once the valve fully expands, the frame, which is crimped, is going to foreshorten now. And this difference between the final height of the frame, the crimped height, and the fully expanded is the foreshortening. So this is the Octacor design, which was already shown in the previous presentations. There's an interlaced octagon and rhombus body. So what was the difference in the engineering and how was it overcome? This we already know. Myval Octacor THV foreshortening is around 19 to 20% compared to the current existing valves, which is 25% and almost 40% for a self-expandable valve. So this was a change in design of the valve frame, and you can see those V-shaped chevrons at the uppermost portion. So just imagine when the valve is fully crimped, these chevrons fold on themselves, and when the valve is fully expanded, they just open up. So really nothing happens to the valve frame height, and this again allows the operator to be very comfortable in positioning the valve when the valve is being deployed. So the foreshortening of the frame is almost 10 to 12%, and negligible foreshortening on the aortic end. So this helps, suppose you have a patient who has low coronary artery, low coronary height, you can just aim for the top end of the valve frame, keep it at the coronary level, and deploy it. Probably this might open new areas and new fields as future, a lot of patients will be getting TAV and TAV, and that's where when you're doing a TAV and TAV, you want a more predictable deployment, how you start with the valve, and that's where the valve pushing should end like. So the Myval Octacor THV design, this we all know, the closed cell, the open cell. The only difference is the chevrons and almost 10 to 12% foreshortening. And let me tell you, when you deploy in a fluoroscopy, you just don't appreciate that 10 to 12 foreshortening which is happening. This is a video here. You can see the crimped valve and the expanded valve between the two yellow lines. It just stays the same. I'm going to let it play again. This allows for a highly predictive deployment and allows the operator to be very comfortable. And the technical thing is, we started doing this again in cusp overlap view, because in a cusp overlap view, there is no parallax in the valve frame and there is no parallax in the annular plane. And that's very important to actually achieve this deployment. Otherwise, if there's a parallax in the valve frame, probably the depth will not be assessed properly. So this will allow the operator to have higher operator control and predictive deployment. Thank you very much.
Excellent.
And more tomorrow's live in-box case, you will be able to appreciate this in real time.
Yeah, so we have a few more moments for discussion, Andreas. We have a few minutes. So, I think what you said was interesting is that it's not perceptible to the human eye. And that was something, people talk about these numbers, but when you bring into clinical practice, you don't appreciate the foreshortening.
So that becomes very important when we start doing this case, because in our mind, we are doing as if we are doing our conventional balloon expandable, and we tend to go deep, and it's not going to foreshorten.
Right.
And then you have to be comfortable to really begin a high deployment as an operator, because then you are scared it will fly off.
Right.
Yes.
So this is just a new learning thing, which takes another 4 or 5 cases to adjust yourself.
I think it's an important message that it's a new valve, it's a different system, and you have to learn how to implant it. The point that Philip made at the very beginning.
Yeah, it is different. I think if you're coming from an ultra background, you have to think differently. There's a nice question here actually about to do with pacemakers and the observation that if your fitting index is close to 1, your pacemaker rate seems to be lower. Should we be using a fitting index of 0.9, 0.98? There's another side to that. Obviously, we don't want to embolize the valve into the left ventricle, so we need to be overexpanded. But one of the other things that we've changed, I think, really in the last 6 months since the MRI sub-study came out, is we aim for a 5% oversize rather than the 10. And that helps, I think, also just the mechanical effect and the pacemaker rates. Speculation, but I think it has a role.
So precise sizing, a little bit of oversizing, but not too much.
Exactly.
Yeah. Ashok, one of the pioneers of this valve system.
I just had another important point to make. I think Ravindra made these points, which are very good. We must remember that this 5 to 10% is actually not in the outflow, it's only at the inflow, 10%. And it's 12% for the 32 millimeters, practically doesn't even shorten. It's so bewildering initially that when you deploy this valve at 70-30, which you expect would end up at 85-15 or 19-10, it just doesn't move. And therefore, it is difficult to implant it. Well, intuitively, it's very difficult to put it at 90-10 and say it'll be 90-10 because you wonder the valve flat. But my point was coming to the fact that it's shortening only at the bottom. The chevrons prevent it from shortening at the top. The chevrons prevent it from shortening at the top. And I think this 5% oversize also comes from the fact, why do we actually oversize these valves to 10%, 15%? What we're trying to get is large effective orifice areas, low PVLs. Well, we know that we have large effective orifice areas with the Myval genre series, and therefore I believe that we should be downing our oversizing to 5%, avoiding pacemakers, learning how to implant Octacors, and that's what happened in Compare TAVI, I think. Deeper implants, we'll soon know the data. We can overcome this.
Yeah, you know, Ashok, that's a good point about the amount of oversizing we actually need. Whatever you tend to calculate at the annular level is actually about 2.5 times that in the supraannular level. So, you know, we have to remember we have that calcium, and that's what's anchoring and sealing us. Although we measure the annulus, the work is being done by the calcium. And so sometimes I think we have been, you know, you got to imagine that these algorithms were developed back in 2002 and were never changed. Someone said 20 to 23, 23 to 26, 20, and every valve uses that range. It doesn't make sense. So I think this idea of, you know, more one-to-one is where we need to go. Andreas, it's...
wrap-up time?
Yeah, it's exactly wrap-up time.
Do we have any final questions?
Is there any questions?
No. Any comments? Any final candidates for the box? No? For the cube? I think you wrap up.
Go ahead, Andreas.
I wrap up?
Yeah.
No, I think this was well, the attempt to really give you an overview about this new system. For the majority of you, this is new. For some of us, we've been with it, with the previous iterations for a while, and we're happy to share our experience. There is evidence. There is now proper evidence in more than 1,000 patients with this valve system in controlled trials that shows it's at least as good, equivalent, non-inferior. There are some issues, some items that we need to address. We learned about the implantation technique, slightly different, so you have to learn something new. We learned about the large range. We learned about the intermediate sizes, and for the first time seen, the new Octa Pro, of which you will see, I think, more in a live in a box and a live case during this week. That was my wrap-up.
Thank you, Andreas. Thank you.